Thank you, Dr. Shah. Good morning, everyone. Now that we've seen all the stalwarts guide us about managing posterior capsular rent and the nucleus at the beginning of cataract surgery, I'll just highlight the things that you should do, should not do, and how you would refer and how one would manage a situation when it goes beyond salvage of the anterior segment surgeon. So, just to give a perspective of dropped nucleus, if we see over the years, literature tells us that about 0.3 to 1.1% incidence is what we face when it comes to dropped nucleus. So this, though it might mean 3 to 11 eyes getting a dropped nucleus per 1,000 surgeries, for a high volume surgeon, this would still be significant because cataract surgery in today's time is taken as something which ideally should not get complicated. So this still is a high number, and we would require to have a clarity as to how to approach its management. The worry is that once we have a situation of a dropped nucleus, there is exacerbation of intraocular inflammation. One can get inflammatory glaucoma and obvious increase in corneal edema, all of which grossly reduce the overall visual prognosis. So why is the management crucial? Because if managed well and managed in time, a lot of these patients would ideally do really well. Many of them would actually reach 20/20 vision, and most of them would reach a quite appreciable, acceptable level of vision. So one of these studies done with a large case series from UK actually showed that more than 3/4 the cases, that is 75% of the cases with a dropped nucleus when adequately and well managed, have a final visual acuity of more than 6/12 at any time after 1 month follow-up. So as Dr. Shah had elucidated in his first talk, the most important thing to probably prevent a dropped nucleus is to have an anticipation as to which cases would be prone to this condition. So conditions like small pupil, pseudoexfoliation, posterior polar cataract, a very hard nucleus, a very anxious patient, in all these situations one should anticipate that things may go wrong. So even for somebody who's well versed with topical surgery, it would be a nice idea that in these situations one can shift to a peribulbar block, so that in case the situation gets complicated, you still have a comfortable patient on the table with whom you can proceed with the long course of surgery. It would also be good to, without scaring the patient, discuss beforehand with him that his case is probably a little different and may require an extensive surgery or may have a little abnormal course. And these things, whichever are discussed with the patient, should definitely be covered in the consent. As a primary surgeon who would essentially deal with anterior segment cases, it's important to recognize the PCR early and recognize the dropping nucleus early, as well shown in the videos by my previous senior colleagues. Now, no attempts should be made to retrieve any nucleus pieces which have really gone beyond the anterior vitreous below, and restrict your maneuvering just to anterior vitrectomy and removal of the residual cortex from the anterior segment. Suture up all the incisions that you have made. At least ensure a watertight hydration so that there is a positive pressure maintained in the anterior chamber and there is no tendency for the posterior vitreous to bulge anteriorly. And refer to a retina specialist for further management. If one has an in-house full-time retina specialist, nothing like it. If not, then the earlier referral, the better. So what about IOL insertion in the primary setting? Now, though generally it would be recommended and most would be comfortable and happy to insert an intraocular lens, one should definitely be sure that there is adequate capsular support so that you don't have a situation of a dropped nucleus complicated with a dropped IOL. Now, in a particular situation where a large hard piece would have gone back or a large complete nucleus would have gone back, it would actually be a good idea to leave the patient aphakic, as I will show in one of my surgical videos later, that it keeps multiple options for the retina surgeon open to remove the nucleus pieces from the anterior root if the IOL is not put. So, is vitreous intervention always required in a case of dropped nucleus? Now, literature suggests that if the piece is very small, there are no evident rough edges, it's a complete nucleus with an intact capsule, or a very morbid physical condition of the patient and a relatively quiet eye, one may consider no intervention just with medical management. But in all other cases, the threshold for attempting a vitrectomy and removal of the nucleus pieces should be little low. So should it be immediate or should it be delayed? Now, multiple studies have been conducted on this, and none of them have found any difference in the final visual outcome or the overall complication rate. So it is not specific that you should immediately refer, or the retina surgery should occur immediately, or it should occur sometime later. Maybe the factors that would determine is availability of the retina surgeon and clarity of the cornea. So if the cornea is clear, retina surgeon is available, one may even do it in the same sitting. And if one is going to refer the patient and it is going to be taken up at a later date, then possibly one may have to wait for resolution of the corneal edema, which may have come in. So I would wrap up my talk with various techniques of fragment removal, for which I will show a specimen video each. So the techniques of fragment removal from the vitreous cavity would depend on the hardness and the size of the retained lens fragments and the concurrent clinical scenario in which the nucleus has dropped. So one can either do a lensectomy using a vitreous cutter, a conventional phaco-fragmentation, a PFCL assisted anterior flotation and retrieval of the pieces, anterior levitation just with suction and then a vectis delivery, or a chandelier assisted phaco-fragmentation, which now is my procedure of choice. Required steps in each of these techniques that I mentioned that definitely have to be done is an adequate port site vitreous clearance, because your instruments are going to go in and come out of the eye repeatedly, and one may cause a peripheral dialysis if port site vitreous is not cleared. The posterior hyaloid necessarily has to be completely removed. Peripheral indentation, once your surgery is over, should meticulously be done to look for any small retained fragments that are entangled in the vitreous base and to rule out any peripheral retinal breaks. So this is a video showing lensectomy with a cutter. So when you have a condition where the dropped pieces are very soft, or essentially it is hydrated nucleus matter or epinucleus, one can take a vitrectomy cutter and on the lensectomy mode, that is relatively high suction and low cut rate, using the endoilluminator as a second instrument, just cut off the entire nucleus pieces and aspirate in the mid-vitreous cavity. This is a case of conventional phaco-fragmentation where the lens has fallen down after a previous retina surgery. It's a vitrectomized eye. So with a phaco-fragmentation, which is just like a normal phaco needle, the nucleus is impaled, brought in the mid-vitreous cavity, and using the endoilluminator as a second instrument, it is slowly fed into the phaco needle and the entire nucleus is emulsified. So this would be what would be the conventional phaco-fragmentation technique. So pieces are slowly fed into the fragmentome and the pieces are emulsified. In case where the nucleus is very hard and where the anteriorly the lens has not been put, one can actually just lift up the entire piece with suction of the phaco-fragmentome with fragmentation off, only the phaco on. Make a tunnel incision, elevate it and just express out. So you do not waste time or you do not have ultrasonic energy running into the eye, and this can only be done if the primary surgeon has not put the IOL. So if you feel that your nucleus piece is hard, you can actually leave the patient aphakic, because the IOL can also later be put by the retina surgeon. Now this is PFCL assisted flotation. Again we see a large hard nucleus. You don't want to do any emulsification. So after vitrectomy, you inject perfluorocarbon liquid, which is a heavy liquid. As you slowly inject it, it keeps pushing the entire nucleus peripherally. And as the eyeball keeps filling up, the nucleus rises up just behind the iris and you can then remove it out with a vectis. So this again sort of saves you from doing fragmentation in the vitreous cavity. Now this is something which I've been doing very frequently. Put a chandelier illumination. So once you do that, what basically it does is it removes the necessity for the endoilluminator. And instead of the endoilluminator, from the other end I insert a chopper. Now you elevate it, bring it to the mid-vitreous cavity, and instead of the endo-illuminator, because you have a chopper, you get a greater purchase on the pieces, and you can break the pieces in the vitreous cavity very easily. So this is like doing a cataract surgery, but not having a posterior capsule behind, so you're not really worried that much. So this, with little bit of a practice, it's very easy, very quick. Plus, because the illumination is not the endo illuminator, it's a chandelier which is a peripheral illumination. Your entire peripheral retina is illuminated throughout the surgery. So any peripheral retinal changes that occur can immediately be picked up. So these were some of the techniques that I wanted to share with you. Thank you for your patient attention. Thank you.